Hello, everyone, and welcome to this webinar. I'm going to give everyone just another minute to join. We're just slightly before time, but I just wanted to welcome you as you all join us today. It's fantastic to see you all and really excited to hear from our speakers today. So I will give you another minute or so to join us, and then we will get started. Great to have you with us all today. My name's Emma Doble. I am the Patient and Public Strategy Editor at the BMJ, and I'm really excited to hear from our four speakers today on the topic of listening differently, embedding the patient voice into diagnostic safety. Please use the chat box to have a chat with us today, share who you are, where you're based, and I also really welcome you to share any questions for any of our speakers in that chat box as well. Our speakers are going to go through their presentations. I think they also have a little bit of interactivity for you all to get involved in as well during their presentation. And at the end, we'll have a bit of time, about 15 minutes or so, to cover any questions that you may have. So please put any questions into the chat box. And yeah, really looking forward to hearing what your thoughts are and any questions. So yes, let's get on with it. I'd really like to welcome all four of our speakers, Kristen, Kelly, Helen and Traber. It's wonderful to have all four of you here, and I'm really looking forward to hearing all of your thoughts on listening to patients in diagnostic safety. So Kristen, I'm going to hand over to you to get us started.
Great, thank you so much. It really is a pleasure to be here. We're excited to present the work that we've been doing through our Patient Partner Diagnostic Center of Excellence, where we are listening differently and trying to embed the patient voice in diagnostic safety through art, insight, and action. I'm Kristen Miller. I am from MedStar Health, which is a healthcare system in the United States in the Washington, D.C., Maryland, Virginia area. And I will get us started here. We have organized this session into a few pieces. And so I'll do some initial framing. Traber will talk about a pathway for thinking with patients about diagnostic safety. Kelly will share how we've been using stories and turning them into insights. I'll talk about how we then take those insights and turn them into concrete and practical ideas. And then Helen will talk about what the impact means, what works, what lasts, and how you can apply this in your own setting. I think the concepts that we're talking about today can be applied to a lot of different quality and safety areas. We focus specifically on diagnostic safety because for us, that's really the entry point for everyone into the healthcare system. You can think about something minor, a sprained ankle, a cold, or something more urgent or severe like cancer or any number of chronic conditions. And we think about patients entering the healthcare system in that way and trying to get answers to questions like, what is wrong with me? What is going on? Why am I experiencing this? And ultimately, that is the diagnosis. And if that's wrong, then everything else that follows is wrong. And so we think this is a really important part of care. And we know that it matters to everyone. So diagnostic error, we're talking about missed, wrong, delayed, or just not communicated well to the patient. Those are all diagnostic error. And it's really hard to even quantify the impact, especially when we think about getting the right diagnosis, but a patient feeling like they just don't fully appreciate what's happened or what the next steps are. We also know that this matters to some more than others. So when we look at certain patient groups, whether it's by race and patients of color, by gender, for women, for specific disease categories like mental health or substance use, patients in larger bodies, all of those groups not only experience more diagnostic error, but the harm that happens is worse. And it's estimated that everyone will experience at least one diagnostic error in their lifetime. So this is significant for everyone. We know that there's a lot of work and sort of renewed energy in the diagnostic safety space over the last few years. But a lot of that work has really focused on the epidemiology of the problem. Where is this happening? How often? And a lot of the solutions then are focused on the clinicians, which is a really important part, looking towards the clinical teams, to leadership, to how we structure healthcare. But we feel like a lot of that has ignored the critical role of the patients. Patients really are the experts of their own bodies and their own health. They have more knowledge than anyone else about what might be going on. And they can also detect and prevent errors in their own healthcare. So our work has really looked to illuminate the blind spot of diagnostic error by re-envisioning what this looks like, and really thinking a bit differently about how we engage with patients in our work. Our goal is ultimately to bridge the gap between patients with lived experience and everyone else, whether that's the clinical care team on the front lines, the researchers that are trying to understand and come up with potential solutions and interventions, and also healthcare leadership. In a lot of our work, we've heard that we're just speaking different languages, that there's these communication gaps between how patients are able to convey their own experience with the training that providers have gotten. And so really, we want to move beyond consulting. We recognize that patients are not just data points. Often we're doing chart reviews, or we're launching a survey or an interview. And in that way, patients just feel like a single data point and not really a partner in designing better care. We also know that one size does not fit all, and different solutions may be appropriate for different settings or different patients. And so our goal is to ensure that solutions work for everyone, that they are relevant, equitable, and usable for everyone. And we know that we can only do this by fostering trust and credibility. And you'll hear a lot about that, building rapport and developing these relationships as we go into this work, really in true partnership. So Traver, I will turn it over to you.
Thanks, Kristen. Hi, everyone. My name is Traver Jardina. I am a assistant professor at Baylor College of Medicine and a researcher at Michael E. DeBakey VA Medical Center in Houston, Texas. So I'm going to talk a little bit about educating, engaging, and empowering patients. So I'll walk you through the 3 ways patients can participate in diagnostic safety and where our teamwork sort of fits into the landscape. So patient involvement happens across 3 modes that sort of build on each other. Patients move along the spectrum based on context, their capacity and need. Education builds awareness. Patients gain knowledge about their role in diagnostic safety. And engagement invites patients to collaborate. So patients can actively participate in their care, but it becomes 2-way rather than 1-way. And then empowerment enables action. So patients can influence systems and drive change. Education sort of creates the foundation, and then engagement activates that foundation, and then empowerment sort of extends that into feelings of real agency. We go to the next one. So again, education in our work is sort of an entry point, right? So we're providing information, and this can look like patient safety checklists, educational materials about how the diagnostic process works, what questions you can ask your clinicians, information sessions on what questions you can actually ask your doctor. So it's mostly one-dimensional, one-directional. We're equipping patients with baseline knowledge so that they understand the diagnostic process. So this looks like, again, educational materials for patients. So an example of that might be a checklist for when you're leaving appointments. So kind of like I mentioned, what questions can you ask? But you can also prepare patients to feel more comfortable about, do I actually understand this diagnosis? Do I know what the next steps are? But again, education alone isn't enough. It is essential, right? We need patients to understand the diagnostic process and how they fit into it. But you can't really meaningfully participate in something if you don't actually understand. we go to the next slide. So moving on to engagement, this is where it gets more dynamic, right? More two-way. So communication obviously is bi-directional, and this kind of looks like shared decision-making conversations, patient feedback loops, safety huddles where patients are actually in the room with care teams and participating. Patients can contribute their expertise, and patients are experts in their own bodies, the symptoms they're experiencing, and just in general, overall, their experiences with the healthcare system. They notice concerns at home, right? Like we know what's going on with our body. We remember details. And patients can ask questions that reveal actual diagnostic gaps. An example can be, a patient reports through the portal that their symptoms are increasing in the evenings. Something that is not going to show up in an office visit. It's engagement. They're collaborating. They're not just complying. But there is a limitation to that. Patients are still operating sort of within the system and the processes that we've created for them. So they're participants in our framework, in the healthcare framework. So if we go to the next slide. So empowerment, patients have agency, as I mentioned, to shape the systems themselves. So this looks like patient advisors on safety committees, not just PFACs or patient and family advisory committees, patients in the safety committees at institutions. It can also look like patient-led improvement initiatives. Empowered patients are not just giving feedback, right? They're designing the solutions that work. And an example might be a patient who has experienced a diagnostic delay, identifying maybe that the portal, so the patient-facing portal, maybe it lacks an urgent concern flag. So they may bring that up in the safety committee. They can work with IT to design the feature, test it, and implement it, because patients see gaps that we don't, right? So in that example, a patient may be experiencing something that is really important. They need their doctor to look to, but there's no mechanism to do that, especially if it's, after. So they experience the barriers firsthand. And when patients have the agency to act on those insights, of course, we all benefit. Next slide. So engagement means being a seat at the table and being heard. Empowerment, we sort of think of it as like having a vote at that table. Right? So co-design sits at the intersection of engagement and empowerment. It's collaborative. It gives patients a sense of agency. So co-design means creating solutions with patients and not for them. And it's an opportunity where patients can learn from each other. And even in our own work, we've seen that we've gotten feedback from caregivers who've said, learned so much from the other patients in the co-design, and they've exchanged emails and they've kept in touch. So it's been really an important opportunity for patients. Also, patients teach us what it's like to live with a diagnosis, how they navigate the system, how they sit with uncertainty. We share what we know, right, about the evidence. We know what the workflow looks like in the system. We know the constraints, but the mutual learning happens in the actual work itself, in the co-design. I would say in our work, the key distinction is the patients are partners, not just participants. Participants, attend, but partners are actually creating, coming up with new ideas to implement. And that's really a mindset shift, because we're trying to think creatively about how patients can be active within healthcare systems. And that lived experience is really foundational to co-design. And ultimately, if we improve diagnostic safety, we need patients at the design table. We need them working with us and showing us what's going on. So everything we present today sort of comes from our commitment to this idea that patients are part in designing safer diagnosis. We do have a little activity for everyone. know we have a lot of folks here. So we'd love for you to sort of think about a project that you're working on, and then sort of think about, where is it? Are you providing education? Are we moving towards education, towards empowerment? Um, and once you sort of think about that project and where you are, what is a step that you could take to move it further? So just take a moment to reflect on that. We are going to keep using this project as we go through. And if anybody is brave and would love to share in the chat, we'd love to see what folks are doing and any ideas you have about taking whatever project you're working on to the next. I think I will hand it off to Kelly to keep it moving. Thanks.
Great. Thanks, Traver. Kelly Smith, I'm the Chief Scientific Officer and Michael Guerin Chair for Patient-Oriented Research at Michael Guerin Hospital in Toronto and an Associate Professor at the University of Toronto in Toronto, Canada. I'm going to be talking a little bit about our work, taking stories and really building insights from stories so that we can advance diagnostic excellence. Next slide, please. So storytelling for us is foundational to the work that we're doing. Patients come, they tell us our stories and their stories about their experiences with the healthcare system in multiple ways. And from those, we learn what matters most to patients, what they're seeing along their journey, because patients are really the only people that are part of the diagnostic journey from the start to the end. And we understand and helps our listening and listening deeply and effectively and actively helps us to build trust and safety and connection. And oftentimes our patient partners in our research come back over and over and over again to participate and eventually help us drive our research agenda as well as our improvement agendas locally at our own organizations. We take these insights learned from stories and deep listening with patients and families to move into that design and change elements. And Kristen's going to talk about that a little bit. Next slide, please. So oftentimes people ask me, where do you get your stories from? Right? Stories are everywhere. We get them from social media. We get them from direct interviews with patients and family members. Our patient experience surveys are a wealth of knowledge from patients and family members. Those free text comments are a gift that we should really embrace and learn from. Our teams have seen diagnostic errors, they have seen patient safety events, we have seen lots of different things observed from patients and family members. And what we really understand is that patients feel like if you have a communication breakdown with a patient or a provider, that bi-directional or collaborative communication, if that's missing in your care team, if it's missing within your provider encounter, oftentimes patients signal that as something is going wrong. They haven't been heard or they haven't been listened to. And those are deeply connected to their diagnostic experience of excellence in the diagnostic process. So just think about all the data that you have at your fingertips and think about how you can leverage those stories immediately to circle back to care improvements. Next slide, please. Great. So one of the challenges that we had in our Diagnostic Center for Excellence was actually eliciting stories from broad and diverse partners. So we went to things like social media, and we also came up with this idea of, could people just give us a call and tell us their story? And what we found is that these stories that patients are telling us are very rich, very detailed, and really they're willing to have that conversation, particularly if it's anonymous, so that they would like to have been heard. When we leverage that information to move towards our improvement and taking those insights that we're learning from multiple patients and move them into improvement for diagnostic safety, what we find is that patients see themselves in the work, which is really exciting. And they oftentimes volunteer their information, their personal information, so that we can get back to them and bring them into the co-design process. Next slide, please. Great. Another challenge that we had is like, how do we make this fun and interactive and interesting? How do we build the bridges in multiple different ways? Because some people aren't really comfortable talking or speaking up. So we worked off of something that is out there in terms of building a mosaic. So our team was trying to build a mosaic from different stories, and we had prompts about tell us a diagnostic experience. What is your lived experience of diagnosis? What do you think diagnostic excellence actually looks like? And we had people paint little portraits. These are 4x4 squares. They're very small, takes about half an hour to do. But this is came from one of our World Patient Safety Days that was focused on diagnosis a couple of years ago. We had this at my hospital, and Kristen's done this as well with medical students and nursing students. And what we find is that people really connect that feeling, the connection. What builds diagnostic excellence is actually empathy coming through as the heart. The heart is prevalent in almost every time we do this. So it's really kind of exciting to see that, we see that diagnosis is an empathy enabled process. It's also a communication enabled process, and those come through in art as well as in words. We also have them describe why they painted what they did. But it's really so exciting to see that there's consistency across the world, both in the United States and Canada and other places that we've brought convened groups together on this. Next slide, please. On our World Patient Safety Day, we had patients do these 4x4 squares as well as providers came in from all over the hospital to do their squares. And one of the nurses had had a really bad day in the NICU, the neonatal ICU, and was just reflected on this exercise. They're like, this doesn't feel like research. This felt like therapy. And she actually asked to take a bunch of the things back to the NICU because they couldn't get away. And so we sent them a bunch of supplies so that they could all have this therapeutic moment together. So just thinking about how research can also impact in the moment, give people space. At this event, we also had a patient who was in the emergency department. He was waiting to be seen in the emergency department. I had to have a test that he was really uncomfortable having. Came down and spent 3 hours with us painting. He painted about 7 different things. We actually gave him some things to go back to the ED with so that he could feel more comfortable. But this process actually allowed him to get the test that he needed. He was too afraid of doing it, but this calmed him down to the point of being able to go back and have this IV put in that he needed to have. So just thinking about how important these touch points are within the overall diagnostic experience. Next slide, please. One of the brainstorms that we were having is that one of our patient partners said, my mental health diagnosis was really like a web. It was off all over the place. And I've been misdiagnosed so many times for physical ailments because of my mental health diagnosis. I really wish we could map this out. It's like a spider web. I get on a roundabout that I can't get off of. So all of these imageries. And then so Kristen convinced her partner to build a web of diagnosis or a web of misdiagnosis where we have individuals come up, take a string of yarn, and sort of plot out their diagnostic experiences. And we learn about where we leverage this information that we're gathering as places that we might want to start to look. So clearly, primary care is a key area. Emergency department's a key area that we might want to focus on as scientists. The types of diseases. So who do we want to focus on? Is there a particular diagnosis that's more prone to misdiagnosis than others? And communication is central from the patient's perspective. So we would be remiss if we didn't have that as a special element. And as you can see here, very few people have misdiagnoses that aren't related to a communication breakdown. And then, having the level of time. So diagnosis is a time limited condition, patients often expect the diagnosis fast, whereas clinicians often think, well, diagnosis is a process, so there's a mismatch in expectations and understanding of the process. So this just helps us to really understand where things are breaking down and where we should be focusing as researchers and improvers. Next slide, please. Great. Another challenge that we have done or approach is journey mapping, thinking about where is my story, where does it start? One of the challenges in that our patients are keep reminding us is that the diagnosis doesn't start when they access the healthcare system. The diagnosis actually starts when they're at home and they're thinking about feeling differently, something's not right, where they have to make decisions, and their clinical decision making starts well before the diagnostic process from the perspective of the healthcare system. So listening and sort of probing and directing and mapping this along, where are the opportunities? Where is the story taking us? Where are the improvement opportunities? All come out through this journey mapping process. Next slide, please. Another big thing that we're seeing in our research was questions, right? Just ask more questions, empower your patients to ask questions, empower your patients to speak up. Our research tells us that patients are pretty afraid to speak up in their encounters. Giving them tools to speak up is great. Encouraging them to speak up. When they speak up, where should they be speaking up? So we did this process with both patients and clinicians about, when is communication most important? Where is shared decision making most important? When is question asking most important? And it's really interesting to see the differences between patients and clinicians in these exercises. But this also gives us an opportunity to learn a little bit about where they think the questions should be asked, and then oftentimes where we should be helping to build bridges around where are the gaps in question answering. And we have a couple of papers on this. It's fascinating that we have looked at resources for patients and family members for asking questions, and they range from, one question per encounter to over 150 questions a patient should ask. So we're really not building our tools in a way that they're usable either for patients or for the clinicians, whether that's inpatient or whether that's in ambulatory care. So this is what we've done in our flash building work and our co-design work, is actually try to make things that are usable for all of the parties at the table. Next slide, please. Ooh. So when you listen for storytelling, you think about what matters most. Patients tell their real stories, what matters to them, and we see a lot of consistent patterns. When you do them in groups and focus groups and bring people together for interviews, you can actually probe and listen and capture sort of not just the feeling and the emotion around what happened, but the actual experiences. So when you tell or share that for learning or try to get adoption of the tool or the toolkit that we've built, we have those stories in hand to help link the head with the heart, understanding the why behind it. And the real stories help us to connect that head with the heart, create that empathic moment between clinicians and patients. Next slide. Thanks. This was a quote, I think it was from a friend of Kristen's who was going through an inpatient encounter. And if you're familiar with the National Academies of Science, Engineering, and Medicine's diagnostic process map, there's the circle in the middle that talks about information gathering from patients. It's really that encounter level piece, that diagnostic wisdom that's coming together. And he called it the wheel of misdiagnosis. The wheel just keeps on spinning. This circle of mystery happens, right? We go in, we share our information, and then something happens to spit out a diagnosis at the end of it. But oftentimes patients really don't understand what's going on. So this provides an opportunity for us to, as researchers and partners in co-design, to think about how we can explain to patients what the expectations are of this circle. Next slide, please. Good. And like I mentioned before, journey mapping is key to this. It's thinking about where the breakdown's happening. It helps us to understand what points are happening and really what the patient, and when you do journey mapping of the same case with clinicians, better understanding as to what sort of the expectations and the decision making and the thinking are from the clinical perspective, and mapping that to what the patients are seeing, feeling, and experiencing. And when you bring those two things together, that really builds up the opportunity for identifying areas of disconnect. And we take those disconnects and try to build tools to support better information exchange at those intersections. Next slide, please. Didn't realize how long my section was. Sorry. So again, these are all the things that we've learned from our stories for diagnostic safety. Listen deeply, listen more, talk less. Not that I'm exemplifying that today. Involve the patient. It's really the wisdom of the patient helps us to improve in ways that we never thought possible. And when we do true co-design, it really is one of those opportunities to see impact in real time. And when patients see themselves or hear themselves or feel themselves in the products that we develop and co-design, they actually take them and use them themselves. They help to advance it up to others. And it really becomes one of those most meaningful parts of my career is working with our patient partners to help improve diagnosis and diagnostic safety. Next slide, please. So it's really important in how we ask questions. So oftentimes healthcare is replete with surveys and other ways of eliciting information from patients. We oftentimes make them closed-ended with Likert scale options, and very rarely do we do open-ended questions. So the next time you think about going into an improvement activity, think about how you can engage patients and family members with that, and reflect on, what makes a good prompt, what makes a good question, how could we elicit sort of a narrative response versus a closed-ended response. There are, pros and cons to both, but the narrative responses are going to give you more of that empathy. You'll be able to empathize with your patient partners, as well as empathize with your colleagues as well, what they're experiencing and feeling. And when you bring both of those teams together, that's where the magic happens. Next, and I'm going to hand it off to Kristen.
Kelly. So I'm going to talk about how we've incorporated storytelling into our rapid co-design. And one thing that I really love about the International Forum, the past few years going to that conference, is there's so much co-design happening internationally, and we recognize that other countries and other groups are doing this really well, whether it's co-production of somebody's individual care plan or co-design of initiatives at a system level. And I think for all of us is trying to move up this ladder. Traber had talked about this being a spectrum where education is foundational, but how do we then move to engagement and then into empowerment? And so in those co-design sessions, we're engaging a diverse group of people, we're capturing their experiences, we're organizing that learning into a meaningful insights, and then we're continuing together on this journey of co-design. I think for us, we've learned so much of this in times that we've done this wrong. And so in trying to constantly get better and learn, some of the key challenges that we've identified is one with outcomes and follow through, that even with the best intentions, when we bring people together for co-design sessions, it sometimes feels like a one-off where we're not following through to say, hey, remember that thing that we worked on? We've launched it, right? And do you want to see the results? And do you have any thoughts about how we can improve it? The timing of engagement can be challenging. If you're engaging too early, then you're not getting concrete enough design decisions that move into the final product. I think we're often guilty of handing something to somebody and saying, isn't this great? What do you think of this thing that we've built? And so we really want to engage at the design phase. The composition of participants can be challenging. We have a ton of expert patients that we work with, and they're fantastic, and they bring maybe more knowledge than some other patients that have trouble navigating the healthcare system. And so we want a mixture so that we have broad representation. We recognize power dynamics just from recruitment and recognizing that we are the research team, but we want everyone to feel like we have shared ownership. We often see people doing the same methods over and over when there are lots of different approaches that you can take in co-design. And then really these practical challenges. If I'm doing a 4-hour session on a Monday afternoon, who's actually able to make that? Who can drive, to my office in DC? That may not be a representative group. And so we really think about time, when we're engaging, if there are childcare needs, and also how we compensate patients. For a lot of the work that we've been doing, again, these common themes about communication and empathy, and just generally, we recognize that clinicians get a lot of training, but nobody trains patients. And this is something that we've talked about often with our patient advisors. A lot of the metaphors that I love of, you take hours of driver's ed before you ever get in a car, or when you get on an airplane, at least you get a 2-minute safety briefing. There's nothing like that in healthcare. And you may be navigating the healthcare system on the worst day of your life, and you don't know the difference between a resident and an attending, or what a specialist does, or what it means to be admitted. There's so much knowledge that we just have not given to patients that might make this a better experience. So with that, we developed a new co-design approach just based on all the things that we've learned over time that we're calling Flash Build. There are a few things that make this approach unique. First, that it's a very narrow scope. We go in with one particular objective. We often go in different directions than where we started. But if we get really off course, we'll take that and say, this is a great idea for a future Flash Build, right? For this one, we want to design this thing that our patients have asked for. We do short bursts of meaningful engagement. So for the sessions that we've done, we typically do them in the evening for 2 hours, one night a week for 3 weeks in a row. And so those 2 hours, we get a lot done. We move from storytelling into prototyping and final design, but they are short bursts of engagement. And I think that actually helps us more than if we just sat people down together for 6 hours. There's a lot of time for reflection and focus work that happens in between sessions. As the research team, we offer ourselves basically as research assistants. We ask the group, what would you like us to do before the next session? Should we do a literature search? Should we go talk to more people? Can we gather more information? Our patients also do work in those weeks in between, those days in between, without us even asking. One of our patient partners drives an Uber, and she said every time somebody got in the back of the car, she was asking them what they knew about AI. We've had patients that have surveyed their friends and family, patients that have developed tools and tried to pilot them in between. And so every time we come back together, there's this wonderful benefit of people saying, I've been thinking about this since we met last week, and I have some new ideas. These are small groups. The research team is about 2 to 3 people and about 5 to 6 participants, whether they're patients or providers. That small group allows for lots of meaningful discussion, and we focus on real products. We do lots of different things in the sessions, but they always start with storytelling. That's so that we can really learn from personal experiences. We also want to build rapport with the research team, but also for the patients with each other. And so we really spend a lot of time, tell me about an experience that you had trying to describe your symptoms to a doctor. Tell me what it was like, the last time that you were in the emergency room. We'll then move on to other activities based on what we're trying to design. So that could be empathy mapping or journey mapping. It could be prototyping or just brainstorming ideas. We also do different prioritization activities. So we take a different approach each time based on what we're doing. But ultimately, we have the same goal, which is to design something together. Like the storytelling that Kelly talked about, the same themes come up consistently in these sessions. It's a lot about trust, and empathy and mutual respect, challenges in communication, in follow-up, in care coordination, and then a lot of stories about equity, stigma, bias, and we feel like we create this safe space where those challenges emerge, and then we design tools to try to address them. Sharing here just a few things that we've built. First was a smart note sheet. This came from patients saying, I have a lot of questions in between session, in between care encounters. I often lose track of them. Can we design something that I could like put on my fridge where I could track different information? So over 3 weeks, we built this tool in partnership with patients called the Smart Note Sheet, S for symptoms, M for medications, A for any updates, R for related visits, referrals, and T things that you're thinking about. One of our patients suggested, can we add something at the top that says what matters most? Because my doctor doesn't ask me that. And I think that they need to know whether I want to run a marathon or I want to walk to my mailbox, whether I want to be at my kid's wedding next year. That needs to be right at the forefront. We also designed a tool to help patients, families, and caregivers better describe symptoms when they are meeting with a clinician, whether it's in the urgent care, emergency medicine, same-day primary care clinic. One of the main lessons we learned out of that is frustration with the pain scale. What's your pain on a scale of 1 to 10? And patients saying like, look, I live at a 7, so that's not helpful. What if you asked me my baseline and then I told you if it had deviated from that? So a lot of really thoughtful insights that went in to just some of the things that we've built over the past couple of years. I'll leave you with just a few strategies that we've learned. I think we've talked about diverse groups and broad representation. We want to make sure that there's equity and inclusion. We try to recruit from different groups, different levels of experience, and we create that safe space where people feel like they can contribute. It's amazing to see the patients sort of bounce off of each other as well. Like, oh, I'm so glad that you shared that. That reminds me of something that happened to me. It really shows that we're building trust in these relationships, and we design the sessions to make it feel that way. We communicate clearly and often. Sometimes patients are anxious about what a session will look like. We always let them know what's happening before the session, and then we inform them what happened after. Last week, we did journey mapping. We learned XYZ. Here's how it's informing our next steps. We want to ensure meaningful participation, so we try to time these again in that design phase so that we can leverage our patients' expertise. We focus on collaboration, and so it really is us saying we're going to build something together over the next few weeks, and we want it to be a tool that works for you, so help us get to that place. And then we plan for implementation and follow-up. In our last sessions, we always say, what is this going to look like? What might be strategies as we roll this out? How should we evaluate it? And then we include our patients in our dissemination, which has been really incredible. If we were doing like a 2-hour workshop, which would have been ideal because we love sort of the hands-on and getting everyone to experience this. I'm sharing one activity that we often use, which is crazy eights. So if you took a piece of paper, letter paper, and you folded it so that you had 8 squares, we then set a timer for 8 minutes, and we ask our patients to draw one idea for 1 minute. And then at minute 2, they move to the second box, so on and so forth. This has been, I think, one of the most beneficial because it's pen and paper, because it's getting back to like rough creativity and coloring. It's not a challenging software program. And then people hold up their papers and they send us pictures, and it's a sort of a fun, engaging moment to say, like, I'm not an artist, but here's this idea that I have. Here's what I think it might look like. And those ideas that influence everyone else to say, oh, I love on section 5 when you drew, that image of the portal, that really got me thinking maybe we could do this as an idea. So just one of the tools that we use in our sessions that you might want to use in some of your co-design. And Helen, I will now turn it over to you.
Okay, thank you. Thank you. Thank you all. So I'm Helen Haskell. I'm an American patient advocate. I'm founder of Mothers Against Medical Error, and I work with the World Health Organization. I chair patient safety at the World Patients Alliance and patient engagement at the Community to Improve Diagnosis in Medicine. So I was a co-investigator on this project. And I just want to, people have really gone into a great deal of detail. I just want to wrap up by talking about some of the practical applications of these ideas and about their broader implications for patients and healthcare workers and health systems. You will have heard a lot of this already, but but I will summarize and add what I have. So we're on the clinician slide. Is that right? Yes. So our topic was diagnostic safety, right? And these tools are all aimed at improving the diagnostic process in one way or another. But our fundamental premise is the basic one that in order for the process to work well, you need good communication between patient and diagnostician. And that means that both of them, not just the patient, need to be educated and engaged. So one of the immediate uses we have found for these tools has been in medical education. Some of us are faculty at a patient safety summer camp for medical and nursing students, occasionally pharmacists, which is run using a sort of melange of methods that include, among other things, patient stories and hands-on activities. And the students are profoundly affected by the patient stories and by their interactions with the patient faculty. They feel safe to tell their own stories, and they have contributed numerous tiles to the diagnostic safety mosaic. This is a way that we get young people at the beginning of their careers to think about their interactions with patients and with each other in a way that they don't usually learn in their regular training. And it's a way of learning that young people are familiar with hands-on activities. It has a long-term effect on them. Next slide, please. And these activities are also confidence builders for people interacting with the healthcare system. You've heard a little bit of that from Kristen, Kelly, and Traber, but the participants in our flash bill sessions, for example, they report feeling validated by the common experiences and emotions that arise during these discussions, and they feel more empowered to speak up later at medical appointments because of what they've learned. Knowledge is critical, as well as encouragement and engagement and empowerment. And for my part, in these discussions, they've surfaced some observations. I thought I had heard it all. They've surfaced some observations that I had never thought about before. Such as the stress for a person with chronic illness of having to maintain a cheerful, amiable demeanor for prolonged periods while they're feeling very ill. And of course, for the health system, having a method to rapidly develop patient-friendly, patient-centered materials is a great way to address gaps that have been identified by patients. Next slide, please. So all these strategies start by listening to patients, and they're driven by patient experiences and by the needs and solutions that patients identify. But designing, patient materials and locating patient stories, it's just the tip of the iceberg. I have a sort of passion for the broad patient engagement. That's what I have really done the 25 years I've been in this area. And I see the fundamental concepts of patient partnership, communication, and patient empowerment have the potential to solve many of the problems that we now face. It is the biggest gap, in my opinion, in patient safety, not just diagnosis, but patient safety. And we can use co-design principles to enhance and improve existing patient-centered practices like family-centered rounds, family escalation of care. We can use them to point the way to new ones. Although we've been talking here mostly about groups and systems, co-design is an absolute benefit and an absolute part of individual patient care. Without it, it's really not going to work all that well. It's something more than shared decision making. and it requires, a lot of sensitivity on the part of the provider to the needs and level of understanding of their patient. But in case, using the power of patients and patient stories, you can develop a system that can recognize, respond to problems expeditiously, and can be made safer by having patients and families as an extra set of eyes. Next slide, please. So I just want to go back for a second to our patient part, talk a little bit about our patient partner diagnostic center of excellence. It's one of 10 such centers established by the American agency, AHRQ. We have not been refunded under the current administration, as I think Kristen or Kelly put in the chat. But our center was guided by a large steering committee of patient and scientific advisors. We had quarterly meetings, monthly learning labs featuring individual members of the team so that people got to know each other and understood the nuances of our research. They helped us develop strategies. They participated in the research. They served as co-authors. They wrote an AHRQ brief with all patient authors. And then they presented our findings at conferences. We tried to involve them in all aspects of the research. And I think the big takeaway is that patient research doesn't have to be boring. In my experience, I don't think there's a whole lot that healthcare providers find more fascinating than hearing true stories of patient experiences. We're hungry to know more about each other. So we've presented here a few ways to operationalize these stories in a creative way. And I think that these open the door to a whole lot of other possibilities. And patients are waiting to be engaged. Next slide, please. And with that, I'd like to thank you on behalf of myself and my colleagues. Our contact information's here, and if you Google Patient Partner Diagnostic Center of Excellence, you can find our excellent website created by our colleague Mary Hill. So thank you for your attention, and I'm going to turn it back over to Emma, and we're happy to take any questions.
So
We
Helen,
did have a
here's one
question
for
in the chat.
you. How do you encourage patients who are hesitant to speak up and share their experiences for diagnostic safety?
I think people are not so much hesitant to share as they need to know the purpose. They need to know it's safe to share. It's not that they usually that they don't want to share, but of course, if they don't, you respect that. But I think just encouraging people and reassuring them that that this is for a good use and that their story is safe with you. Let's see, what else have we got here? I see that you all have been answering questions in the chat, and I have not been looking at it.
There was another question earlier around individuals who are sort of insiders to the healthcare system experiencing differences in diagnosis communication with their providers. So one of the questions was around what have we seen in the literature and what have we seen in research around providers as patients and their experiences of diagnosis.
I'm looking at the question. I think part of what she's asking is assumptions are made about your knowledge and that you may have more knowledge than you in fact do. And I've experienced that as, an assumption that that you're a very educated patient and things are not necessarily explained that you don't know, because being an educated person and an educated patient are really very different things. So yeah, I think that, one has to not make assumptions, but also not insult anyone's intelligence. And so it's a fine line to walk about how you present things. Ask if they don't know, apologize for asking a basic question if that seems to be what they're how they feel about it. Is that answering the question, Janice? I guess communication failure specific to the healthcare provider as patient population. It's a
Yeah, I
fascinating.
think, Helen, to add to, because I think we've all seen this in the sessions we've done with patients, is um, not knowing that you can ask questions. Like I remember we were doing one workshop and we said, if you were getting this new diagnosis, what questions would you ask the doctor? And my little table said, like, well, I wouldn't question the doctor about anything. And like not realizing you totally can. And so giving them the words to say, how do you know this is my diagnosis? If it's not this, what else could it be? What are options for next steps? And so I think it really goes back to what Traber had shared of getting people into that part where they feel like they have agency and respectfully can ask for clarification. Because I do feel like that's one of the biggest challenges of patients leaving. Like, I have no idea what just happened. They said hypertension. I don't know what that means, and I don't know what to do. But it is okay to ask, and training the providers to say patients are going to have questions, and can we sit with those?
And one of the really valuable tools in places where it exists is the patient portal, where the visit is summarized or the medical record is summarized, and so you can find out. Go back and look at what happened. The next one that I see is from Peter Gideon. Are there specific obstacles in implementing each stage of the patient role, especially for LIC and LMIC settings, and how do you recommend handling them? I think that to me is an enormous question. I would love to see some input on that. How it is different in different parts of the world. I don't know if you all have anything to add to that. I think from the little I know that if you really try to educate people, they respond, even people with, never mind low health literacy, but low literacy in general. People want to be engaged in their own health or their family's health. I know there was a wonderful project in Uganda that with medication safety that really engaged the patients by educating them.
Helen, I'll just jump in here too. Many of the tools that we've created with the Agency for Healthcare Research and Quality in the United States have been adapted and adopted worldwide. So I've worked with many countries and the patient safety organizations in many countries to help them adapt it to their organizations or their even to make it more culturally sensitive, have worked with them on adapting our programs and processes and toolkits. So our goal is to make things simple. That the principle of keeping it simple to actually improve adoption. We also work with addressing tools to make them available for and responsive for individuals with low literacy. So even the size of words, the number of words that we use, is really targeted to make sure that they can be accessible to multiple individuals, including low literacy, because we do know if you have a lower literacy level, you do have higher safety events, higher risk of safety events. So we do try to pay attention to that when we are designing our outputs.
I wanted to mention just quickly, one of the things we try to do is meet folks where they are. So there's always going to be obstacles when otherwise, but it's really important to figure out where folks are and where they're ready and to be patient. If you want to succeed long term, it is labor intensive. You do have to put men working with patients. I just saw a question about paternalistic environments, that how do you engage patients in those? And that's sort of, at least in the US, right? Like the entire healthcare was sort of built on that ideology. It's hard to escape. But there are things that, we can do as folks in the system, and not to belabor it, but an idea may be to create a patient advisory panel, even in, smaller systems, even in private clinics, because there are patients there who will help you. There are patients who are willing and able to speak out. And that's, just kind of starting where you can and building from there. You can reach patients that, have been determined hard to reach. It's just putting in the work to meet them where they are, to be willing to engage with community, to be willing to go out and meet folks. I just wanted to throw that in there too. It's definitely labor intensive.
Yeah. Yeah, no, that's great.
process.
And you've done a lot of work like that in Houston.
Amazing. Thank you all so much. I'm hoping you can hear me and see me just to very quickly wrap this session up. This has been a wonderful session. Your presentations were all fantastic. All of the speakers have their email addresses there, and I'm sure they won't mind you sharing all of the questions or any thoughts with them directly. But yes, just a huge thank you to all of you, Trevor, Kristen, Kelly, and Helen for your insights. It's been wonderful. And thank you all so much for joining us today. It's been a fantastic session.
Thank you. Thank you, everyone, for coming.
Thanks.
The next one that I